Well, Mark, I'm excited that we're finally having a conversation that is being recorded.
We've tried a lot, haven't we?
Yeah, you and I get to geek out on this all the time, but we never record them. Um, so, for folks who don't know Mark, he's the director at the Center for Diabetes and Mental Health. He's based in San Diego, but honestly, does a ton online and has been an expert, I would say, in doing teletherapy or mental telehealth therapy for a long time. And I thought it would be awesome to have Mark on and share sort of his experience delivering mental health care over Zoom video. Because I think it's a little bit mystifying for people to imagine that often. Um, yeah, so that's why Mark's here, and he's going to share his brilliance. Mark also lives with type 1 diabetes, so is double qualified, and I think it's going to be really great.
Great. Well, thanks, Adam. Well, glad to be here.
Yeah, I thought we could just start with sort of a general question. What's your experience been like delivering mental health care over video?
Yeah, it's been interesting. So I started doing mental health care with video about 5 years ago. My practice specializes in people with type 1 diabetes. And so I only see people with type 1 diabetes for diabetes specific mental health concerns. And so since there aren't very many providers, I get lots of requests around the country for services. And I realized that I had the ability to provide services to people who didn't live in San Diego. And so about 5 years ago, I started doing telemental health, and it's been a really interesting experience. It's been great from my perspective. When I first started, I was a little bit nervous. It's a little bit nerve-wracking to think, how do I move from this model that I was trained in, sitting in a room with somebody and working with them, to working with somebody over video. But what I realized is really quickly that it actually, while it's weird for about 2 minutes at the very beginning of treating with the person, it gets very comfortable very fast. And that's been my experience. And that's also been the experience of people that I worked with, that I've been working with. I've had patients that I've worked with over video who I've never met before. I've worked with them for a long time and I've actually never met them. I have patients who I've worked with for a long time over video and then met them. Which is a little bit of a strange experience. And then I have people who I've seen in person, and then for whatever reason, they either moved away or they have had transportation issues, or now with COVID, we're doing all telemental health. So people who have transitioned from in-person treatment to telemental health treatment. And for the most part, it's been a really great experience. I'm very lucky that with the whole stay-at-home order, my infrastructure was already set up to provide this type of treatment. And it's I think that people are really finding it to be really valuable, and just as valuable as it would be coming to my office for the most part.
And one question that I imagine some people don't know the answer to is, you are licensed in California, right? You're a
Mm-hmm.
psychologist, which means
Yes.
how does that work? Like, you can only see people in California, is that right?
For the most part, yes. Yeah, so since I'm licensed in California, I can only see people who are physically located in California. There are a couple of exceptions. There are a couple of states that offer something called guest licensure, which means that as a licensed psychologist in California, I can see somebody in that state for a certain number of days a year. So for example, I have a patient who's in Colorado. And Colorado allows for 20 days of guest licensure from an out-of-state psychologist per year. So basically that person is the only person who I can see, because I can only use 20 days a year. And so if I had more than one patient in Colorado, I'd have to kind of have some creative scheduling to make sure they fall on the same days. But the general rule, and that doesn't apply to all states. Only certain states allow this type of licensure or guest licensure. So the general rule is, yes, I'm only able to see people who live in or not who live, but who are physically located in California at the time that I'm seeing them for treatment.
Got it. And then I imagine another thing people are thinking is, what is it actually like to be in a therapy session? Like, how do you log on? And is it like this Zoom webinar? Is it totally different?
Yeah, it's almost exactly like this. So in my practice, I use a system called DoxyMe. It's DOXY.me, which is a HIPAA compliant telehealth system. So people log into a website, and I have a personal website. They come when they go to that website, they get to my waiting room. They put in their name, and it shows up on my screen as this person's waiting, and then I start the call with them, and it shows up just like Zoom. Zoom is also an option for people who want to do telemental health. Zoom is HIPAA compliant, and so you can use whatever system you want, but people who are doing telemental health want to make sure that what they are using is a HIPAA compliant system, just to make sure that the patient's privacy is protected. For example, FaceTime, last time I checked, is not a HIPAA compliant system. And so while the president did allow for, he did, over the situation with COVID, the president actually waived a lot of the HIPAA requirements. And so right now people can do therapy over FaceTime. However, it's not something that I would recommend. I recommend that people use a secure system just to make sure that the therapeutic relationship is kept as private and as secure as possible.
Yeah. Well, yeah. And on that note, the relationship is so important in therapy. Like when you look at the ingredients of people doing better in therapy, like relationship is so key. And I imagine like a lot of people wonder, can I build a relationship with you, Mark? You are a stranger to me if I'm like coming to your practice. Can I build a relationship with you over video, or should I just wait until all of this shelter in place lifts and I can like see you in person? And what would you say to folks who are thinking, like I'm ready for therapy? Should I wait till it's in person, or should I just like go for the video version right now?
Well, I think there's a couple answers to that question. The first is how urgent is this issue? I mean, if you're having a mental health issue that you need to have addressed right now, and there's not a therapist that's available to see you in person because they're not seeing patients in person in your area, then I would say by all means, telemental health is certainly a great option. I think that the other thing, if your issue isn't urgent, you want therapy, but you think it can wait a little while, it really depends on your comfort level and what it is that you're looking for. I think that there is a learning curve and a comfort. I'll call it a comfort curve in terms of starting treatment. But what I have found, quite honestly, is people who have sought treatment for me or with me for telemental health, or people who have been forced to do it because of the COVID situation, have actually eased into it very well. And it's actually been, I think, for them and for me, surprising how easy it's been, and also how that relationship hasn't really been affected. As I said before, there's patients that I've seen and helped tremendously, who I have actually never met in person, never laid eyes on. And I would say that our relationship is just as strong as it would have been with somebody that I would meet in person. I think it's partially a perception issue. How is this going to work? But I think that if we think about, I think there's a lot of parallels here. But we think about Uber. Like 7 years ago, 8 years ago, none of us would ever have thought about pushing a button on our phone and getting into a stranger's car. We would have thought that was like off the wall. And now we do it. Well, we used to, and hopefully we will again do it on the regular. And so I think the same thing is true for telemental health. 5 or 6 years ago, we would have thought it was really strange to see a psychologist over video. But now, with the changing times and the changing technology, I think it's become much more accepted. And I think that people are really, finding value in it.
I love that answer. And the first part of it, you said, how urgent is it? And I'm wondering if there are ways you can give folks who are listening, like ways to assess that. Because I think sometimes it can be actually hard to know like when to seek care and when to kind of wait it out. Are there things that people can do on their own that would help them assess that?
Yeah, I think that the first thing to do is ask yourself, how much is the issue that I'm dealing with impacting my ability to function in the world? So how much is it impacting my relationships with my friends, family, significant other? How much is it affecting my ability to go to school or to work? How much is it impacting my ability to live my life? And granted, I understand that right now we're in a strange time, but that's the biggest. That would be the biggest thing I would think about. And because if you're having trouble going to school and having trouble, functioning at work, then I would say that's a sign that you need some help and probably need it soon, because you have a pain point. You need to have you need to have that pain point addressed. If you're, or with a diabetes specific example, if you're, having an issue where you're emitting insulin to lose weight, or you are running your blood sugars really high because you're scared of low blood sugar. Those are things that are relatively urgent. And of course, if you're thinking about hurting yourself or have suicidal thoughts, that's another red flag. Although we'll talk about that in a minute related to telehealth, because that's a challenging situation. If you feel, I'd really like to talk to somebody about issues from my past, or about my diabetes diagnosis, and trying to kind of come to terms with that. I would say that in general, that's probably a less urgent thing, but certainly it's something that needs to be addressed, and so something that can be put off. But I think the big thing that I would look out for is, how is this impacting my daily functioning? Am I able to do the things that I need to do to live my life effectively, and to pay my bills, and to have relationships?
Yeah, I love that. Is there, for some of the common mental health stuff that you see, I mean, there's lots of good depression screeners. Are there any you recommend? I mean, depression, anxiety, diabetes, distress. Are there ones that you would send people to just sort of get a sense of like how clinically severe or not things are?
Yeah, so I usually send people, before they come in to see me, the PHQ-9, which is a 9-question depression screener. I also will send them the diabetes distress scale to see how they're doing with diabetes, because everyone that I see has diabetes, and so we want to kind of see how they're functioning as related to diabetes distress, and how diabetes distress may be impacting their lives. But honestly, I would say that for patients aren't I would really caution against people self-screening with self-administering these tools. They're available online, but I think that just asking yourself the question, how am I feeling and how am I functioning, is probably sufficient to know whether or not you need treatment. If you want to do the screeners, want to do the assessments, then that's great, but I wouldn't put too much stock in it, because you really need to understand kind of what it's looking for to really get some value out of it.
Yeah, well said. What about finding a therapist? So this is a whole big topic, I think. And I think sometimes people with diabetes, if issues relate to diabetes, there can feel this pressure, like I need to find a therapist who has diabetes. And I'm wondering, like, well, one, what are your thoughts on that? And if I can't find a therapist who has diabetes, which I'm sure you'll address, how do I assess if someone will be a good fit for what's going on for me?
Yeah, well, in terms of finding a therapist, you really want to you want to really ask yourself, what am I looking for help with? And if your issue is diabetes specific, so for example, you're experiencing diabetes burnout, or, fear of hypo or hyperglycemia, or trouble adjusting to a diagnosis, having someone who understands diabetes, I think, is really important. The person by no means has to have diabetes. I know lots of wonderful therapists who work with people with diabetes who don't have diabetes, but they're diabetes knowledgeable. And I think that's important for a couple of reasons. One is that some of these issues are diabetes specific, and so a therapist who doesn't have that expertise isn't going to know what to look for, and they're not going to be able to really address the issue appropriately. And the other thing is an issue of language and connection. You want someone who's going to be able to ask the right questions and to be able to use the right language. And so I get a lot of people who come to see me, and they say, well, I went to see a different therapist who didn't understand diabetes. And I spent a lot of the time in my treatment session explaining to them what diabetes was and what it means when I say that I was scared of, or my blood sugar went low, or that I forgot to take my Lantus, because they had no idea. And that language barrier is a big issue. If you, on the other hand, though, if you're seeking treatment for a non-diabetes related issue, I think that there's no reason why you need to have a therapist who has diabetes or even understands diabetes. There are actually some great resources. Beyond Type 1 has some great resources for therapists who are seeing patients with diabetes for non-diabetes related issues, just to give them a general rundown about what Type 1 diabetes is, and what types of things to look for. But for patients who aren't seeking treatment for something specific to diabetes, I'm not convinced that that's really necessary, especially because there aren't very many people who treat diabetes-specific issues. In terms of finding a therapist, the best resource I have right now is the ADA, APA, mental health, diabetes mental, I can never remember how to say it, the provider directory. For those of you who don't know, the American Diabetes Association partnered with the American Psychological Association about 3 years ago to develop a training program for mental health providers to give them the basics about diabetes and mental health. So it's a one-day training program with some follow-on video work that gives a general idea, a general rundown about what diabetes is, how it's treated, as well as an overview of diabetes-specific mental health conditions. And people who complete that training are now listed on a website on the the ADA's website. And you can do a search based on location, based on state, based on seeing adults or children, and a variety of other things, including telehealth and whether the provider does telehealth.
Yeah, that's awesome. It's been interesting for me because I'm in school to be a therapist right now,
Mm-hmm.
and the training, every strand of training like has aspects that apply to diabetes, but of course, like we don't cover diabetes as a diagnosis, but we certainly cover things like depression and anxiety in great depth, and a lot of those touch diabetes. And I think what you were alluding to is like, if the problem, if diabetes is something in someone's life, but it's not like driving the core problem, like the therapist sort of needs to keep it in the back of their head as like one of many variables that might be affecting the person. But if it's like the core thing, then that's a different story, I think, is what I heard you saying. And that nuance is really important.
Yeah, I think that, and there's one more thing I would add to that, is if it's the core thing, then yes, or if it is something that is having a big impact on someone's ability to manage diabetes. So let's imagine for a minute, just hypothetically, that somebody had a fear of spiders, and that fear of spiders somehow was making it so they weren't taking the long-acting insulin every day. I would say that that is a diabetes-specific issue, even though the fear of spiders is not related to diabetes. It's a big barrier to the person taking care of themselves. And so having knowledge about what taking care of yourself means and how to overcome that barrier in order to get to the end goal of managing diabetes well, that's important. But yes, I think you're right. If somebody has a fear of spiders and doesn't have any impact on their diabetes management, then seeing a therapist like me is probably actually not the best use of someone's time. They should probably, or maybe even my time. Because honestly, I'm not trained to treat people for fear of spiders. I can do it, but my expertise is really in how do I help people to overcome the specific psychosocial barriers that come along with living with diabetes. And so, seeing me for that issue, even though you have diabetes, we're probably not the best fit.
And Mark, do you think? So let's say, it's a diabetes thing and I need a therapist who specializes in mental health and diabetes, and yet there's no one near me and there's no one in my state, for instance, or no one's seeing patients, like we could come up with a bunch of reasons. Yep. What about therapists who are like really solid on like disabilities work or really solid on chronic illness? Like, to me, there's enough similarities that like you could make a lot of progress, but I'm wondering if you disagree, or is that?
No. I absolutely agree. If you can find someone who's trained in health psychology, there are lots of psychologists who are trained in chronic illness over the span of illnesses. That's really helpful, because that type of therapist is going to know enough to be able to do the research to understand kind of where the person's coming from and have the theoretical basis for that. Also, I know that myself and also other psychologists who specialize in diabetes are always happy to consult with therapists when the issue that the person's dealing with is diabetes specific and the therapist doesn't have that sort of expertise. I don't consult nearly as much as I'd like to, because I think that we could be a lot more value than we are right now by being able to support other therapists in providing treatment when we are not able to.
Hello, friends. There are some questions in from the audience.
Sure.
One in from Anonymous. Thank you, Anonymous. Mark, what types of diabetes-specific concerns have patients been seeking help for during these wild global pandemic times that we're currently trying to figure out?
Yeah, so it hasn't been a whole lot different than normal, but certainly a lot of the conversations that we've had are around anxiety around COVID, and and how, and especially over the past week, how the current unrest has been impacting people's just feelings of safety, which certainly impact and comfort, and that certainly impacts and the stress, and how stress impacts their diabetes management and their blood sugars. But other than that, other than that specifically, generally speaking, the issues that we've been dealing with are really the same: diabetes distress, diabetes burnout, adjusting to diagnosis, fear, concerns about relationship with healthcare providers, guilt and shame. But certainly, those stresses have been amplified by the current times.
Yeah. Your signature includes the fact that you are a certified diabetes care and education specialist. I got it right on the first try.
Good job.
Do any of your appointments or discussions with your patients involve things like settings changes? Like that's part of the thing. And if you're licensed to like engage in that, like how far down the like specific diabetes treatment or diabetes management and treatment do you address as you're talking about the mental side of things? Do you also address the legitimate, not legitimate, but the actual sort of mechanics of diabetes management as well?
Yes, well, to a degree and to a limit. So I will not change somebody's pump settings or change somebody's basal rates. But sometimes I will suggest that they may talk to their doctor and want to increase their basal rate or increase their long-acting insulin a little bit. But I leave those decisions to the doctor. That's really not my expertise or my place. Where it does come in a lot is providing education about what diabetes is and how it's managed, and certainly some of the factors which impact diabetes management. Because I think and I'm a really big believer that diabetes education is a psychological intervention. If people are diagnosed with diabetes and don't understand it very well, and they're kind of, they're feeling lost, that's going to increase anxiety. And so providing good education about what's going on and how, strategies that people can use to manage diabetes better and more effectively, that gives people something to hold on to and something to, a feeling of more control over their condition, and a sense of efficacy that they have the ability to manage it well. And so to the degree where it's important and necessary, I certainly do. One thing I try not to do is talk about my own diabetes in treatment. Certainly, I don't, everyone's diabetes is, if you know one person with diabetes, you know about one person's diabetes, and my experience really doesn't translate to anybody else's. I do, however, one thing that I will do sometimes is show people my CGM graph. Simply because I want to show people that I'm a professional here, and I do this on a daily basis, and I'm a certified diabetes care and education specialist. Got it right too. But my diabetes management, or my blood sugars, are by no means always in range. And I think that's an important thing to have people understand, is that like it's okay that sometimes you're out of range, and I use that. One thing I will say though on that note is one of the challenges that we have with telemental health is looking at CGM graphs and looking at like kind of sharing those resources in person. That's one downside that we can't do that. It's harder to do it. You can kind of show your CGM graph over video, but sometimes it ends up being backwards and hard to see because of lighting. So
have I a free solution for you if you're looking to view your patient's diabetes data? Tidepool.org/telemedicine. That was not a plant, but by the way, you can view your patient's diabetes data from the comfort of your home. And your patients can upload from home, by the way, as well. One more question from Christy that I'm going to hide for a little bit. Thank you, Christy, for your question. Mark, do you recommend giving the diabetes distress scale during an appointment or prior to the appointment? What about folks who don't return it?
I believe that the diabetes distress scale is in the public domain, and so if they don't return it, I don't think that's a big deal. I mean, the only issue would be if they filled it out, put their name on it, and then left it somewhere for their own privacy. But yeah, I would definitely recommend giving the diabetes distress scale for two reasons. One is that so the therapist can understand kind of what's going on with that person at that point, and see if there are specific areas that they need to address. So for example, if the person has an upcoming appointment with their physician and they're scoring high on the physician distress subscale of the diabetes distress scale, that may be an issue that you can address during treatment. The other reason, which I think is actually just as helpful, is to be able to see change over time. Oftentimes within therapy, it's hard to measure progress. And so by using the measures over time, you can see and also show back to the patient, their improvements, so they can actually see if they're making progress, which for them is usually that provides them some hope.
Right on. For everybody else out there, thank you again for your questions. If you have any more, use the Q&A button at the bottom. Take it away, Adam.
There's also a couple tools in mental health that have been used. There's like the session rating scale and the outcome rating scale that are really awesome. Basically, they take like 10 seconds to fill out, and a person just marks it off. And you discuss it with the therapist or provider. And the research behind this shows that the client's perception of how the therapy is going is a better predictor of outcome than the therapist's perception of how therapy is going. And this is a way to surface concerns that the client may have but may not say. But if you sort of externalize it to these tools, it allows people to, and then you can measure changes over time. So they're free in the public domain. We'll link to those when we do a follow-up blog post, but those are really cool. And my school is a really big fan of those.
Yeah, that's awesome. I think that you hit the nail on the head there, that the patient's perception is much better than the therapist. I tell you, I see patients and I say, I'm not sure how I'm helping this person. I'm not really sure if I'm doing them any good. And then I will ask them, and they'll give me a list of reasons why they keep coming back, and how what we're doing is so helpful for them. It's always a surprise. It's always a pleasant surprise for me that that's happening. And this is both in person but also over video.
I'm wondering, do you have a way of asking that? Because I imagine that in the medical field, often a doctor might not ask a patient that, but it would be a lovely question to ask.
Yeah, I just say, I'm curious, how is this helpful, and how, and I also don't want to bias the question. So I say, how is it helpful, but also how is it not helpful? Because I want to open the door for people to tell me. I'm not fishing for compliments or fishing for praise. I'm really looking for feedback and really looking for understanding. But I also want to know, how things are not helpful and what's not helpful about what we're doing, because that's just as important, if not even more important than what is helpful.
Yeah. There was this question I heard, I think it's more used early in therapy, but it's like, what would good therapy look like for you?
Mm-hmm.
And I thought that's also like a lovely question that would almost never be asked, at least in my experience in the medical field. But in the mental health field, it's like, tell me like, what would a productive, awesome relationship therapy look like for you?
Yeah, I think another way of asking that question is, what will you be able to do when we're done here that you can't do now?
Yeah.
Because if we're really looking for, and this is my perspective on therapy, if we're looking at, the person is seeking treatment because there's a barrier to them living the life they want to live, and we want to get them to the place where they're going to live that, be able to live that life. And so it's both a process, but it's also an outcome. And I think that they're just as important, but really we want to get to the outcome and not have the process last longer than it needs to.
Love it. Mark, what do you think is misunderstood about mental health in people with diabetes?
Lots, especially for people who don't live with diabetes or don't know somebody, have a close person in their life who lives with diabetes. The first is that they're connected, and that, having diabetes, the diabetes is not only a physical condition, but it's also a mental condition. The burden of diabetes management, or and actually I'm trying not to use the word burden as much anymore, but the workload of diabetes management can be overwhelming sometimes, and that staying mentally healthy is an important consideration to staying physically healthy with diabetes. And also, but when you need to address mental health issues at the same time that we address physical health issues. The second thing is that these challenges are normal. Diabetes is a stress, and that when people are experiencing challenges with diabetes, oftentimes that's a normal reaction to stress. And we often pathologize that, and certainly we want to help people to deal with the stress better, but it's not a pathology. Living with stress and diabetes, that's a normal part of diabetes, and sometimes there's just no way around that. And so we want to help people to understand and normalize that's the case. Next, that these things exist on a continuum. Certainly, there are some people who have major mental health issues related to diabetes. And I think that the best example for that on the far end of the continuum would be somebody who doesn't take insulin to lose weight. And that is both, that is extremely dangerous physically. It can send you to the hospital and possibly worse very quickly. It's also a very serious mental health condition. But I think that everybody with diabetes, or most people with diabetes, especially type 1 diabetes, have some sort of stress, whether it's just kind of some negative emotions, frustration, feeling alone, feeling isolated, feeling different, to having kind of some major issues, and everyone in between. And so I think that we need to see that it exists on a continuum. And then, of course, that with mental health issues that are related to diabetes, how important it is for the treatment provider to understand what diabetes is and how it's treated, because you can't use a one-size-fits-all approach here, and certainly we want to do no harm, and oftentimes by not understanding what diabetes is and how it's most effectively treated, and also the language around it, the culture around it, you're going to be talking at cross paths, and therapy, generally speaking, will be less effective that way. So that was kind of a mouthful, but I think there's a lot of things that are misunderstood, especially certainly by people with diabetes sometimes, but also by people who don't have diabetes, who are struggling to understand what the big deal is. And it is a big deal.
Yeah, that was lovely. The other thing I would tack on that I think touches on some of those is I think people don't understand how interconnected diabetes is with the rest of life, and in reverse. So just to give like a simple example, like if I'm anxious and find it harder to fall asleep and I sleep poorly, and then sleep connects to blood sugars in like a really strong way. So the next day I might have like much higher blood sugars, but then of course my blood sugars also influence my mental state and emotional state. So like for me, like when I'm high, I'm pretty grumpy, and I just know that. And then, of course, all of that can build further anxiety or further stress, and then make it more difficult to fall asleep. And so, like, I think there's a lot of positive feedback loops that happen in diabetes. Like, the coping strategies make the problem worse, or the coping strategies in this area influence this other thing over here, and all of that ties back to diabetes.
Yes.
And I think there's often this oversimplification of like, well, just count your carbs and take your insulin and check your blood sugar, and you'll have on-target numbers. That ignores like how tightly connected the web of diabetes in life is.
Yeah. Well, and even if you have on target numbers, it doesn't mean that you don't have emotional challenge related to diabetes, because for lots of reasons, which we don't have to go into now. So, and I think that it's important for physicians to understand that, and I'll hopefully always ask their patients the question of, how you doing? How is this impacting you emotionally? Even if blood sugar numbers are right on target.
Well said. Chris.
Hello, friends. 2 questions, one from Anonymous. Thank you, Anonymous. How can we prepare patients for a good telehealth session? Any pointers, any suggestions on how to get your patients ready for something like that?
Absolutely. A couple of things. One is you want to be in a private place. When you come to a therapist's office, you're in a private place by default. But when you're home, you want to make sure that or wherever you are, you want to make sure that you are in a place where you can focus, and where you're not going to have distractions. So turn notifications off on your computer, make sure that no one's going to be disturbing you, and really focus. I have a patient who told me recently that he always lights a candle next to his computer before we talk, which I didn't know because I couldn't see it, but I thought that was brilliant, because he was able to kind of set that time aside. one thing I've realized when you go to a therapist's office, like there's a beginning and end. So you make an effort to drive there or take transportation there. You walk in, and all of a sudden your treatment has begun. And at the end, you walk out the door, and your treatment is ended, and you have some time to decompress and to think about it. When you're at home or in your office, that delineation isn't as clear. And so I think making that delineation very clear, like, taking some time to turn off the computer afterwards and just kind of, think about, what did we talk about? What did I commit to changing? How can I do this? Is really important. From a technical point of view, I think that honestly, I've actually never asked anybody this, but I've noticed that I have some patients who use their cell phone versus using a computer or a tablet. And from my point of view, it makes it look very thin and makes them look small. But I would imagine that I think that that using a computer or a tablet is a better option. That's just my gut. Simply because it's not something that you're playing games on and looking at Facebook on it. It's kind of you're able to kind of have that have that space. Also, I think that it's important to come in with an agenda, or come in with if you have something that you want to talk about, make sure that you have that written down, and make sure that you're able to address that. I always try to ask that to my patients when we first start a session, whether it's in person or over video. But I think over video, it's even more important to make sure that that your needs are known, just because it's harder to get a sense about the person's nonverbal communication over video than it is in person. And so if somebody has something they want to talk about, I want them to address it as soon as possible. I always try to ask, but I also want them to know that. And it also structures the session and gives the session more structure. I always make an effort over video to make sure that our sessions are much more structured, simply because it makes it more comfortable and makes the process go much easier. And I think people get more out of a structured session than they do of, hey, how's it going? And then kind of diving into wherever things go. So those are the general tips that I would give. And I'm sure that there are more, but that will come to me later. But I'll leave it at that.
I mean, we are promising at some point a follow-up blog post. So as they come to you, and whenever you're taking a shower or whatever, you can just jot them down and let us know. We will get back to you on that one. Another follow-up question. This is actually from me. I'm going to be careful how I word this. Automated insulin dosing systems, either in development or actively available. One of the goals across the board is to take on some of that burden, some of that process of diabetes management. How have you seen conversations with your patients change as hopefully, in the case of any sort of success with automated insulin delivery systems or dosing systems, whenever patients are able to offload some of that, have you seen how patients or conversations are changing because they're devoting a little less time, no matter a lot or a little less time to diabetes management, they're able to focus on other aspects and potentially adjust the nature and scope of conversations that they're having with you?
Yeah, I mean, I only have some anecdotal observations here, but the patients that I have who have started on automated insulin delivery have definitely noticed a decrease in cognitive burden and kind of cognitive load and related to diabetes management. And so that's been for many of them it's been a game changer for them. And their diabetes distress, especially around low blood sugars, around waking up, around sleep, have really increased. Have really gotten better. And so I've seen nothing but good things. Certainly, the issues that come up are around trusting the system and making sure that that what's happening is that they're comfortable with, both in terms of the blood sugar, but also in terms of their anxiety, because taking that hands-off approach, I've heard and I know can be a little bit anxiety provoking, but generally speaking, with a little bit of time, I've seen that go away. But at the same time, I think that it's important to recognize that automated insulin delivery does not all of a sudden take away the mental health burden of diabetes and the emotional burden of diabetes. A lot of the guilt and the shame and the stress and the embarrassment, that's still there. Or it may actually even be there more. Someone who wasn't using a pump before now has a pump on, and that's a physical reminder that they have this invisible condition. For a lot of people, that actually brings on some more stress. And so I don't want people to think that Automated insulin delivery is amazing. I use it, and it's been a game changer for me. But I don't want people to think that if we put people on AID systems, that all of a sudden their emotional burden is going to disappear.
That is, yeah. There's a lot to unpack. It's a whole other webinar. One more question in from Paul. Thank you, Paul. Mark, can you comment on the impact, if any, of mindful meditation on diabetes management? I mean, there are apps out there like Calm and Headspace and things like that that are that sort of focus on that specific aspect of mental health. Any impact, if any, that you've noticed from people either using those apps or engaging in more direct mindful meditation?
That is my favorite question. I love mindfulness, and I love talking about mindfulness in relationship to diabetes. For those of you who don't know, mindfulness is paying attention to your experience in the present moment without judging it. And I think that that mindfulness has such a huge impact on diabetes management. There are so many benefits that you can use, from paying attention to what your reactions when you see your blood sugar number on your CGM or on your meter, to noticing how you feel when your blood sugar is high or low. And not judging your experience, but just taking the action that you can to change it, change what you can, and also recognizing that there's some parts of the experience that you can't change, and to be okay with that. And so I'm a big fan of using mindfulness in terms of in helping people manage diabetes and especially around acceptance of diabetes. I find it to be especially useful for people who are overwhelmed with diabetes and the cognitive burden of diabetes, as well as people who are struggling to accept the fact that they have this condition. I've seen a lot of patients recently who are newly diagnosed in their 20s and 30s, and for them that adjustment is challenging. And so using mindfulness as a way to help them to accept their new normal and to embrace it, rather than to try to avoid it or push it away, has been extremely helpful for them. So I can talk for probably another hour about mindfulness, but those are the ways that I have found it to be very helpful. I think that the apps out there are awesome. I use Headspace personally, but Calm and Fabulous is another one that has mindfulness integrated into it, are all great options. And I think that one other thing I will say about mindfulness is a practice, which takes practice. You can't just say, I'm going to be mindful today. You really need to practice that skill. And so using an app or using some sort of an audio program to help you to practice that mindfulness skill will help you then to use it in your everyday life with diabetes when those types of stresses come up. So.
And Mark, you use acceptance and commitment therapy a little bit or a lot? I can't remember.
Yeah, I use acceptance commitment therapy, otherwise known as ACT, a lot. And ACT is a mindfulness-based therapy where, and for those of you who don't know, ACT is a therapeutic model, kind of in the same realm as cognitive behavioral therapy, where the goal is not to make the symptoms go away. So for example, with diabetes, stress or diabetes burnout, the goal of treatment is not to get someone not to be burnt out anymore. Although that's oftentimes an outcome, the goal is to help somebody to accept the fact that they're burnt out and to live the life that they want to live, even though they may feel something they don't like feeling. What we find is that by doing that, oftentimes people actually feel less burnt out. But that's not the explicit goal. The explicit goal is for people to be able to have that outcome that I asked about before. What do you want to get out of therapy, and what do you want to be? How do you want things to be different, even if the symptoms don't go away? Because we can't always make symptoms go away, and we certainly can't make them go away at the snap of a finger. But what we can do is teach people skills to allow them to live a full life that's in line with their values, even if they're experiencing symptoms that are not pleasant or comfortable.
I love that. There's a related modality that Mark knows well called DBT, and there's this video that we'll link to when we publish this, but they talk about this balance between acceptance, like I'm doing the best I can, and I have this thing, and change, and like that dialectic of acceptance and change. I think we see all the time as people with diabetes, like I'm accepting that this is hard, but also like I need to do something different. And it can be really tricky to like balance both of those things. But I think mindfulness is also a core component of DBT, and like can be such a good tool, for doing that.
Yep.
Mark, maybe just to wrap up, what are your sort of recommended tools, books, resources? What do you give people, I guess virtually, to kind of help them with this stuff? If maybe they can't afford a therapist, the therapist isn't covered. Yeah, what are your go-to things?
Yeah, so what I will say is that in my experience, and this is again the world according to Mark, but if we had 100 people with diabetes, there are probably 2 people who need to see a therapist. And then there's another 97 or 98 people who need something, but that's not necessarily a therapist. They need some sort of mental health support. I think those things kind of fall into 3 different categories. The first is social support and peer support. So I always recommend organizations like Connected Emotion, Friends for Life, and Children with Diabetes, and TCOID as ways for people to connect with other people with diabetes and really see what other people are experiencing and normalizing people's experiences, but also really empowering people, because seeing other people with diabetes living lives that are not without barriers put in place by diabetes can be really, really powerful. I'm a big fan of books. I know there's a great one by some guy named, I forget his name, Adam Brown, Bright Spots and Landmines, that I recommend to everybody. Actually, I think it's right here. It's actually holding my computer up, so I'm I'm at level. And also Diabetes Burnout is a great book by Dr. Polonsky. It's a great book that I recommend. And then, of course, I think there's lots of web resources out there. So Diatribe is a great option. Beyond Type 1 is a great option. And I'm actually in the process of developing a new website called The Diabetes Psychologist, which is going to have a lot of resources for people with diabetes around the mental health aspects of diabetes. Not up yet, but hopefully will be up in the next couple of months. So I will be recommending I recommend all of those things. But I think there's lots of resources out there that are great and that can really provide a lot of helpful tools that don't require therapy, because certainly I think everyone could benefit from therapy, but not everybody needs therapy, and it's not the best use of time or money for most people with diabetes.
Awesome. Mark, this has been lovely. Chris, I don't know if we have any other questions, but I just want to say...
other questions in from the chat. I do want to say that Dr. Polonsky is in the audience, so hi.
I saw that. So good plug, Mark. Awesome. Well, Mark, any parting thoughts, wisdom for people to take away in this maddening time?
I think that stay mindful and really know that your experience is normal right now. I think that people are always looking for solutions, and I think that sometimes we take this problem mindset to mental health challenges. If I have this problem and I need to get rid of this problem. And I think that for a lot of times that's a really effective strategy, but there are lots of also times when that strategy is not particularly effective because these challenges around diabetes or just around our times aren't things that we can solve. And so looking at it from a place of acceptance and a place of how do I deal with things how do I deal with things now and deal with them effectively, even if I can't make them go away, is a really is a great way, is a winning strategy, because we want to set you up for success. And if you can solve the problem with what's going on for you, then that's success. But if you can't solve the problem, or if the problem is not solvable, we've got to have a different metric for success. And I think there's ways to do that that we've talked about today, and that we can certainly that we can post resources on for folks. And that's both for providers as well as for patients.
Right on. I like that closing note. So everybody, Tidepool.org/telemedicine. If you have any questions about anything else that we've covered, or you want to get started using Tidepool as a potential resource to view your patient's data remotely, we can certainly help you out there. As a reminder, in 2 days, Dr. Jill Weisberg-Benchel will be joining Adam for a conversation about mental health tips for parents and teens. That will, as promised, be a banger, I promise. Again, support@tidepool.org is email just if you have any questions about this or anything else related to your Tidepool experience. There actually is one late breaking question we're going to get to. Oh my goodness. Hang on one second. Brittany has sent in one last question. We'll end it on this one. So she's saying, I had to step away for a minute and miss the tools and tangibles that you recommend giving to clients. If you would please share. So I guess, Brittany, two things. One, this webinar is recorded. It will be going up on our YouTube channel in like 3 hours from here. So we'll be able to cover that there. And two, there will be a blog post at some point to follow up on this, which will have direct links out to all of the resources that we're talking about here. And we'll make sure that that is as comprehensive as possible there. So rather than revisit everything, stay tuned. And we will make sure to get all that information out to you and everybody else who's paying attention to the archive, hello, out there in YouTube land, for all of this. So thank you for chiming in, Brittany. Thanks for coming back around to ask for that. Hopefully we can get you, if you don't feel like we've addressed your questions sufficiently, again, send a message to support@tidepool.org and we'll get back to you as quickly as possible. So that is it for us here in this Tidepool for Telemedicine webinar. Dr. Heyman, thank you. Adam, thank you for steering the ship. I'll see you in 2 days. Everybody else, be safe, take care, keep up the fight. Have a good day.